I ran to a colleague of mine who's speaking at the Hodgkin's session. She has about 5 people there. And because we're curing, 90% of patients with Hodgkin's lymphoma. And you're all here because this is a disease which tends to come back and requiring new and novel therapies, and that's what we're going to be talking about. Okay, anyhow, that is a lymph node. That's when we take out one of your lymph nodes and we slice it and put it on a slide. That's what it looks like. It is these nice organized. Is there a pointer, Sam? Sam, you still here? Yeah. Is there a pointer? Because the arrow is not shown yet.
Let me check. There you go.
Now the pointer showing up. I like that.
Problem solved.
Those little circles are the follicles, from whence comes the term follicular lymphoma. Good. And follicular is derived from the germinal center of the lymph node. And the various other indolent lymphomas, which are distinct from follicular lymphoma, we used to lump them all together, come from different parts of the lymph node. The mantle cell lymphoma comes from the mantle zone. The marginal zone lymphomas come from the marginal zone. The germinal center also is from where certain types of more aggressive lymphomas come from. Diffuse large B cell, one of the subtypes, Burkitt lymphoma, and even Hodgkin's lymphoma.
Question? What's the actual size of that thing on the slide there?
It depends how big your lymph node is. A normal lymph node is about up to 1.5 centimeters. It differs based on what part of the body it's in. In the chest, it may be a little bit bigger, and the neck, it may be a little bit smaller. If that was your node, you'd be in trouble. And for those of you who are, shall we say, metrically challenged, 1.5 centimeters is 2.54 centimeters to the inch. So that's the normal size of a lymph node, is 1.5 centimeters. Okay. Now, so that was the organized lymph node. This is what you see on the top left of a lymph node biopsy of a patient with follicular lymphoma. Those circles are now all over the place. They take over the whole lymph node. And when you look more carefully at the cells under the microscope, you see that they are those are the cells. They're considered small, and they have clefts or folds in them, small cleaved cells. And in the peripheral blood, this is a blood smear. Sometimes you will see the cells in the blood smear, and the one on the top right is called a buttock cell. I'm waiting for this one to sink in. It was named, I guess you could call it a plumber cell. Named for Dr. Buttock, who was a real pain in the... Anyhow. When a biopsy is done, your doctor will sit down and tell you you've got grade 1, 2, 3 follicular lymphoma. This is what it means. It means kind of not much of anything. But grade 1 lymphoma has fewer than 5 larger cells per high-power field on the microscope. Grade 2 is 5 to 15, and grade 3A is greater than 15. The only reason we do this is to give the pathologist something to do, because clinically they're about the same. And if you biopsy different nodes, it may be a grade 1 here, a grade 2 there. The one that's important is the grade 3B, because here the arrow is pointing to a small lymphocyte. The rest of the cells are sheets of these big cells. So this behaves more like a large B-cell lymphoma and is treated as such. But the 1s, 2s, and the 3As are pretty much a wash. You've heard about staging of lymphomas elsewhere, so we're not going to go into that unless you ask questions later. About 80-90% of patients with follicular lymphoma have widespread disease at the time of presentation. Only about 10 or 15% have limited disease, that being stage 1, one isolated lymph node site, or stage 2, that being 2 lymph node sites on the same side of the diaphragm. I'll just show you one slide for stage 1 disease because I can bet there isn't anybody in the room here who has stage 1 disease. But this just shows you that the time to progression is the same no matter what you do in stage 1 disease. You can radiate them, you can give them chemotherapy and radiation, or you can do nothing, which is what I generally do. And patients do just fine. And then when something happens, they can be treated. I've got patients that have more than 15 years who I've never done anything to with stage 1 lymphoma. They're doing just dandy. But 80 to 90% of the patients have more advanced disease. And this is a study which I think is now accepted for publication. And I'm only showing you this rather than all the other studies out in the literature, A, because it's a study that I'm an author on, but B, because it's fairly recent data. With it was a randomized trial we did with R-CHOP versus CHOP followed by radioimmunotherapy, which I'll be talking about at lunch. And it just shows you that the time to progression at 10 years is about 50%. So 50% of patients with advanced disease who get this kind of treatment are still without progression at 10 years. And the bottom slide shows you that about 80% are still alive at 10 years with advanced stage disease. And this is just with R-CHOP, and we have better treatments than this. So the outcome is far better even than these relatively recent data. But what we've learned is not all patients are created equal. And we try and develop prognostic scores. So when a patient shows up, we look at certain clinical laboratory features and say, you're more likely to do better than the person in the next room. The one that has been used most often for follicular lymphoma is called the FLIPI, which is Follicular Lymphoma International Prognostic Index. It has nothing to do with what you did to that guy when he cut you off this morning driving in here. And it's NOLASH, nodes, LDH, age, stage, and hemoglobin. And if you look at the bottom, low risk is 0 or 1 of these features, intermediate is 2, and high risk is 3 to 5. And the 10-year overall survival, as you can see on the far right, goes from over 70% down to 35%. This is with older therapies. This study is back from 13 years ago, but it just gives you an idea. But it doesn't tell you how to treat patients. It's just there. You can give a patient a risk, and this actually may not hold true with some of the newer, better therapies. But we're in a more molecular genetic world now, and we're trying to find better ways to predict how patients are going to do rather than things they can't control, like their age and hemoglobin and things. What about the more molecular, down to at the cellular level? A couple of years ago, these investigators came up with what's called the M7 FLIPI, in which they look at the FLIPI, the performance status, which is how you function in life, 0 being normal, unrestricted, and the overexpression or overactivity or underexpression or underactivity of a number of genes. And some of these are just kind of genes, but there's one, particularly EZH2 on the right, is actually a target for a new drug that we have in clinical trials called tazemetostat. So this divides patients, still not perfect, into low risk in the top 2 curves and intermediate risk, but the bottom is the bad risk patients. I mean, they're so far worse than the other groups. Those are the ones we need to focus on. Those are the ones who, before they're ever treated with standard therapy, we know they're not going to do well with standard treatment, and we have to find different approaches for those patients. Now, this is one of the most widely shown slides in follicular lymphoma land. and this is the one I talk to my patients all the time about. The left are patients treated in what was called the National Lymphocare Study with R-CHOP, and the right is what's called a validation cohort, meaning another group used the same treatment to see if the results came out the same. And they sort of did. And what this shows is that follicular lymphoma patients can be divided into two groups after treatment. There's one group, the top curve, which comprises about 80% of patients, fortunately. And these patients have a survival that is consistent with an age-matched population without lymphoma. And I believe firmly, and I know some of my colleagues disagree firmly, some of those patients are cured. That's 80% of patients, and you distinguish these two groups by whether they've had an event within 2 years of treatment. So if you haven't progressed, if you've got a complete remission, you haven't progressed within 2 years, you're on that top curve. If you've progressed, then your survival is down from 80, 90% down to around 40%. Another group that needs to be focused on, and there will be a national trial looking at that group specifically. Can we predict those ahead of time? We're trying to do so.
Just to be clear, what do you mean by progress?
Progress meaning the disease has grown. It has come back. Progress in our business is bad for you. Regress is good. Progress is bad. In anyone. Progressive disease is increase in size, increase in number, increase in symptoms. Progressive disease, bad for you.
But I think are you really looking at people after they received their first treatment, whatever that
This is after first treatment with R-CHOP, this slide.
What about after first treatment with radiation?
No, with radiation, we only do that for the limited stage disease, and I showed that on a previous slide, like, oops, going the wrong way. I showed that. There. Radiation is the red line.
If no progression and within 2 years after radiation?
No, those curves are just for advanced disease treated with R-CHOP.
Dr. Cheson, can you repeat the questions for the audio? Thank you.
She asked whether those data pertain to patients who were treated with radiation as their primary therapy. The answer is no.
Is 2 years a hard cutoff, or, obviously, you're not talking 720 or 30 days, so.
You're talking 2 years. Now, having said that, it's a silly number. The FDA has agreed upon 30 months as their, what we call, surrogate endpoint. If you're doing a clinical trial in follicular lymphoma, they take 8, 9, 10 years to do. And by the time they're done, you don't really care about the treatment anymore because you've got new stuff. And you really don't want to wait that long to get a new treatment on the market. So we try and find ways to determine what's better at a certain time point. They've accepted 30 months based on a trial that I'll show you later called the relevance trial. There are now 2 groups that have demonstrated the 2-year mark, and one group actually suggests that maybe at 1 year. But the most data suggests that there is, if you look at this curve, it really, I'm going to get killed here. Those are the best data. So that's what I tell my patients. If you haven't relapsed by 2 years, you're likely to have an excellent outcome. Doesn't mean you're not going to relapse and require additional treatment. But your survival is that. That's not progression-free. That's overall survival. Okay, the question, I guess everybody heard that one because he's in the back of the room. And if I can hear it, and I'm deaf, I'm sure you all can hear it. What? Huh? What's that? Feelings. Okay, enough of that. Enough frivolity. This is cancer here. The way I follow patients depends on their response to treatment If they get a complete metabolic response, meaning their PET scan is negative 6 to 8 weeks after completion of standard therapy, then I don't get another PET scan unless there is a suggestion of recurrence. I see them every 3 months out to this point in time, get blood tests, poke around. It's a funny business. The first thing you do when you meet a new patient is stick your fingers in their armpits. No one else has that delightful experience. If the patient says at some point in time, I'm feeling another lump, or, the fatigue is back, or I'm starting to have sweats again, then I'll scan them. In contrast, there are patients who have a partial response, meaning it's not all gone. There is some left, but it's more than 50% gone. That person I will scan at infrequent intervals, because depending on where it is. If the nodes are in the abdomen, I can't feel them, I can't see them, I'll get a scan, maybe in 6 or 9 months to see if there's more progression. If there isn't, maybe not for another year or so. If there seems like there's a bit of progression or that it's near some important organ, then I may get another scan in 6 months or so to make sure that things aren't growing in a place I can't feel it. Everybody I manage a little bit differently depending on the clinical circumstance. We get blood samples on everybody. It is not very often that they provide useful information. Sometimes you'll notice a little bit of progressive anemia, lowering of the red blood count, or thrombocytopenia, lowering of the platelet count, suggesting involvement of the bone marrow. Sometimes the LDH test, that's not lipids, that's lactate dehydrogenase, may start creeping up. There are some subtleties in the blood test which may suggest, particularly in concert with symptoms, that something is going on. We have better tests, which, now that I took out 35 slides, we can get to later.
Let me just get to his point.
Your wife, huh?
Yeah.
No wonder.
Next month will be 12 years in complete remission post-R-CHOP.
Okay,
And he's going to go to the doctor.
fine.
He doesn't want to go get
Fine,
blood test or go.
fine. I would expect that there is a modest chance, better choice of words, a reasonable chance he's cured. And I know people will violently disagree with me. We are now getting ready to embark on a study that will prove that in certain patients. I can't tell you what it is because I know anybody's stealing my idea. But we're going to be looking at patients just like him. Anybody who's 2 years out and following him sequentially. I got a whole clinic of people who are out 10 and more years in remission, relapse patients who I treated them with some of the newer therapies, still in remission 10, 12 years later. I'll believe that a proportion of them are cured, and I'm going to prove it. Say hallelujah. All right, never mind. Okay, now, one of the strangest conversations that we have with patients is, okay, you've got lymphoma, which is a form of cancer of the lymph system. Your disease is advanced, meaning you've got it in multiple sites. Is that an air raid? Under the table. Didn't they teach you that when you were young? Under the table, right? Okay. And we're not going to treat you. Anybody in the room had that conversation with their doctor? Oh, yeah. Scared the out of you, didn't it? Well, we have a lot of patients we don't treat. Watch and wait, or in your case, watch and worry. And that's based on a couple of clinical trials in the past where patients were randomly allocated to early intervention versus observation and treatment upon progression, and there was no difference in outcome. Now, these are patients who didn't immediately need treatment. Well, how do we know if you immediately need treatment? A few years ago, these criteria came out. You can defer treatment in patients who don't have bulky disease, for example. We use arbitrarily 7 centimeters as a cutoff, or fewer than 3 sites of 3 centimeters. Patients who don't have symptoms. Patients don't have a big spleen. Patients who don't have fluid collections in the chest or the abdomen. People are not at risk of their lymph nodes compressing something important. I got a lady now, I'm trying to convince her to get treated. She doesn't have a bulky nose. She's got a node in her neck. It's right pushing on her, her major blood vessel in her neck. If it grows anymore, she's going to have a stroke. She doesn't want to be treated. Patients who have lots of circulating lymphoma cells in the blood should probably get treated. And cytopenias, meaning anemia, low normal white count, low platelet count. If you don't have any of these things, you can be watched and waited. And I'd say at least a quarter of my patients I've been just following for years and years and years, no treatment. If you start developing these, then it's a discussion with your doctor. I'm starting to have fatigue and, got a couple of lymph nodes. Well, is it interfering with your quality of life? Is it interfering with your function? No. You want to be treated? No. Okay, let's watch and wait. Those patients I'll follow a little more carefully. See them every maybe 2-3 months, depending on how advanced it seems getting. If they say, I can't run anymore. I used to be a jogger, and this first it went from 5 days a week to 3, and now I can't do it anymore. Then, okay, let's get rolling. So it's an individual discussion. There's no cookbook for this. It's more art than science.
When the first-line protocol was R-CHOP, if somebody had a complete remission after 2 treatments, would you have stopped or continued for the other 4?
We don't know. Now, how do we get to 6 treatments, okay? This is a secret, so don't tell anybody. Way back when, in the Wayback Machine, way back when, this chap named Vince DeVita. Vince DeVita was the head of the lymphoma program at the National Cancer Institute, and then became the head of the National Cancer Institute, and then became chief of medicine or something at Memorial, then Yale. Anyhow, he developed the first curative chemotherapy regimen for Hodgkin lymphoma, a regimen called MOP. It was nasty stuff, but no one before could be cured with chemotherapy. And so when he developed this regimen and he was finding these great responses, his colleagues said, well, how much should we give? And he said, how's about 6 cycles? And that's stuck for every chemotherapy regimen to this date. That is the origin of 6 cycles. I kid you not. I kid you, but I kid you not. That's the answer. So I don't know. I don't know.
So you have to follow it as a medical doctor?
We do it. If he had a metabolic complete remission, we might have stopped, but we don't do interim scans in follicular lymphoma. That's a no-no.
That's interesting. He had
I know. They all do it, but you're not supposed to do it. Read Cheson et al. Because there are false positives like crazy. And just because it's negative doesn't mean it's not going to be positive at the end of treatment. The best determinant is 6 to 8 weeks after standard chemotherapy. Cheson et al., 2014. I trust him implicitly. So the patient does need to be treated. What's the best treatment? Well, what we do know is it's got to have rituximab in it, or some anti-CD20 monoclonal antibody. I'll talk about antibodies at lunchtime, to the point where you won't want to even eat lunch. This simply shows the bottom curve on these 3 are chemotherapy alone, 3 different regimens. The top curve is when you add rituximab or Rituxan. So in every chemotherapy regimen in follicular lymphoma, it prolongs survival. We know that. But which of the chemotherapy regimens is the best? I don't know. Well, I do know. There was a study done by the Italians called the Follow-5 study, and they compared our CHOP, our CVP, and our fludarabine mitoxantrone, which no one uses, this side of the big puddle. And what they showed was here, the time to treatment failure with our CVP was the worst. That's the lower curve. Goes down quickly. The other 2 curves are pretty similar, the RFM and the RCHOP. But when you look at toxicity, the likelihood of anemia, neutropenia, thrombocytopenia infections was greater in the red bar, which is the RFM. So R-CHOP, as effective, less toxic, less filling, tastes great, became the standard. But then along comes bendamustine, which is a drug I brought into the United States from East Germany. It was a drug designed to be a cheaper version of Cytoxan, and what it amounted to be was a more expensive version of Cytoxan. Anyhow, in this German study, they compared BR with R-CHOP, and you can see that it was markedly different in the time to disease progression, and in this study, it was less noxious. So this has been adopted by around 80% of doctors now as the standard therapy in the United States and in most of the world for follicular lymphoma. There are some exceptions which we won't even get into. Now, okay, since the curves go down and down and down and down, it means patients aren't being cured. They're continuing to progress, meaning get worse. Okay. So what do? Well, intensifying therapy, giving lots more courses, more doses, doesn't do it. What about maintenance therapy? Giving more rituximab or some other drug for a prolonged period of time. I preface this by saying I am the nihilist for maintenance therapy. There have been 5 studies now. I don't have room on a slide for 5, so I'll show you 4, showing survival by maintenance. The differences are insignificant in all of these studies with regard to survival. So maintenance therapy has expense, nuisance, and doesn't improve your survival. And if you don't get it, you can get it again if you need it in the future. It's just like, why do we watch and wait? Well, every treatment has toxicity, expense, nuisance, and newer, better things are coming along all the time.
How does Bexar and Zevalin compare with R-CHOP?
Can you repeat the question, please?
Yes. The question is, how do Bexar and Zevalin compare with R-CHOP? They have never been compared with R-CHOP, but I showed curves before of trying to add them to R-CHOP, and they prolong the time to progression after CHOP, but the survival is actually worse because of the risk of secondary cancers. And I'll talk about that at lunchtime. So what can we do? What can we do? Well, we can get the hell away from chemotherapy and try and use more targeted treatments. Anybody mind getting away from chemotherapy? All right. All right. One of these is a drug called lenalidomide. Say that 3 times fast. You win a prize. Lenalidomide, lenalidomide, lenalidomide. Blah, blah, blah. This is a drug which is called an IMiD, or immunomodulatory drug. And by itself, it has modest activity in follicular lymphoma. But when you combine it with rituximab, this is in the initial treatment of follicular lymphoma, a study that we just published. The response rate, complete and partial, 94% of patients responded with 94, 96, 95%, depending on the Flippy score, responded to this treatment. This is no chemo. Lenalidomide's pills. You take 1 pill 21 days in a row, you get a week off. There are some side effects, but plus rituximab. Does it last? Well, yeah, in our study, 80% of patients are still without progression out at 6 years. No chemo. And the group at MD Anderson has shown data which look even better, and that's because they're from Texas where everything's bigger. So we invented this regimen in 2004. And what has happened since, based on these data, is there was a large international randomized trial called the Relevant Study. In the Relevant Study, R squared, which is rituximab and Revlimid, was combined with our chemo, our CHOP, our CVP, or BR, followed by maintenance with that regimen or rituximab-only maintenance. 1,000 patients, studies done. We don't have the data yet. But if this turns out to be superior to chemo, this will change frontline therapy. And this is a study in which the FDA has agreed to use 30 months as their surrogate endpoint for if one regimen is better than the other, rather than waiting for 8, 10, 12 years.
Can you repeat this again, please? This slide?
Can you repeat?
Can I repeat? Please. I am repeating. I said please. Okay. This slide is a large 1,000-patient clinical trial in untreated follicular lymphoma, randomizing patients to R-squared rituximab Revlimid versus R-chemo, R-CHOP, R-CVP, BR. Each of the arms is followed with maintenance for a couple of years, either the R-squared maintenance or rituximab-only maintenance. We don't have the data yet.
If you had Rituxan 6 years ago, are you untreated?
This is frontline only. We'll get to the relapse setting when we talk about the relapse setting.
Is there any preliminary sense about what the efficacy is?
Nope. It is a randomized trial. They will not release the data before its time.
What are the side effects of lenalidomide?
There are a lot of them. It has been associated with an increased risk of clots, although when you combine it with rituximab, that seems to be less for some strange reason. It can reduce blood counts. It can cause fidgetiness, irritation, nausea, and the biggest one we encounter is a really, really, really bad rash. But most patients tolerate it well.
What is it?
It is an immunomodulatory drug. Its mechanisms of action include it acts on T cells, B cells, natural killer cells and macrophages, and the microenvironment. And that's where it probably has its most pronounced effect. The lymphoma cells live in a microenvironment which has cytokines and chemokines, all kinds of these proteins that feed the cells and keep them alive. This interferes with a number of those pathways. It's not really totally clear how it works, but there are multiple proposed mechanisms of action. What else can we do to improve the outcome? Well, maybe there's some better way to have a CD20. There have been at least 10 attempts to improve on rituximab. Most of them haven't stuck to the wall. But obinutuzumab, can you imagine saying lenalidomide obinutuzumab? Is one that is an interesting potential alternative. It has different functions, the way it interacts with CD20 than does rituximab. But you don't care about this. What you care about is, does it work? So we'll show you that. Recently published, like last week, was a study called the Gallium trial. The Gallium trial was a very large, randomized study in previously untreated CD20 positive indolent lymphomas. That's follicular, marginal zone, most of them. And patients received randomly either chemotherapy with bendamustine, CVP, or CHOP, with either G, which is obinutuzumab, Gazyva is the trade name, or R, rituximab. And then they got maintenance with the same antibody. So a head-to-head comparison of the two antibodies. The results are shown here. Median followed with 3 years. There was a significant prolongation in the time to progression or progression-free survival. It reduced progression by 34% compared with rituximab. Survival, no difference whatsoever. And there was a bit more toxicity with regard to febrile neutropenia, infections, infusion reactions, that's what IRR is, in favor of rituximab. So you have prolonged time to progression with no survival benefit and a bit more toxicity. I don't have time to go into the nuances of the study and the subgroups. There may be some patients who will benefit from this and should receive it, and others probably won't benefit from it. And which chemotherapy is the preferred one is also the subject of controversy. Now, most patients with follicular lymphoma will recur. And what do you do then? Well, there are a number of agents that are approved for the treatment of relapsed and refractory follicular lymphoma in the U.S. There is Y90 ibrutinib tioxetan. We got loads of cool names. Also known as Zevalin, a lot easier. Bendamustine alone was approved, and bendamustine, as I'll show you with obinutuzumab, is more recently approved. Idelalisib, copanlisib, R squared, is not yet approved. If that's approved for frontline, it will probably get approved in the relapsed refractory setting. And allogeneic bone marrow transplant is used, not autologous in most places. Now, the Zevalin data, just to be brief, is easy. Day 1, day 8. You get non-radioactive antibody on the first day, so you can tell that it's going to the right place, and then you get the therapeutic antibody on day 8. That's it. No 6 cycles, no nothing. Slam dam. And about 4 to 6 weeks later, the blood counts go down a little bit, then they come back up again. Does it work? Yeah, it works. About 80% of patients will respond to it. I call this the most active, least used treatment of lymphoma. About 80% of patients will respond to it. Many of these are complete remissions. And there are some patients out there 8 years later still in remission on this drug. But we don't use it. Why don't we use it? Well, number one, it is associated with an increased risk of leukemia and myelodysplastic syndrome. Number two, most doctors can't do it in their office, so they got to send the patient someplace else. Most doctors don't like sending their patient someplace else. 3, it's not done everywhere, so most of the patients in the world don't have access to it. And there are certain restrictions based on the amount of lymphoma in your bone marrow, blood counts, that sort of stuff. So there was another one out there, the I-131 drug, which isn't even on the market anymore. That vanished because no one was using it. And this one is bouncing, that was Bexar, and this one is bouncing around from company to company to company and still not selling. But more targeted is a drug called idelalisib, Zidelig. This was approved a couple of years ago by the FDA based on this study in patients with third relapsed, primarily follicular lymphoma. And the response rate was 57%. 6% got complete responses. But the median time to progression was 11, 12 months. So you got a year out of it. It is a pill. You take one pill twice a day. But the problem is the side effects. I call this the itis drug. Itis means inflammation. It gives you colitis, inflammatory bowel disease, transaminitis, increase in liver enzymes, pneumonitis, inflammatory lung disease, and dermatitis, a rash. If you don't get it, and it doesn't occur, and it occurs in a minority of patients, if you don't get it, it's a fantastic drug. If you do, it's a nightmare. So it is really not widely used very much, unfortunately, because it's really a good drug, if it doesn't make you sick. And if you do use it, you need to be on prophylactic antibiotics because even more recent studies suggest an increased death rate from strange and unusual infections. Everybody want to run out and get it now? Okay. It is one of a class of drugs called PI3 kinase inhibitors. Another one was recently approved by the FDA called copanlisib, same class of drug, PI3 kinase inhibitor. In this case, the overall response rate was 59% with 12% complete remissions, about the same. The time to progression was 11 months, exactly the same, but it appears to have fewer side effects. But this drug is given intravenously day 1, 8, 15, and then you get a week off. And then day 1, 8, 15, then you get a week off, and that goes on as long as it works. So we are in the process of trying to develop a maintenance strategy that doesn't involve that many injections. The other drug you probably heard about is ibrutinib, which is extremely active and approved for CLL, mantle cell lymphoma, Waldenstrom's macroglobulinemia, all those indolent ones, marginal zone lymphoma. So you would think it should work in follicular lymphoma, but it don't. This is a study that we just submitted for publication. It's called the DAWN trial. I don't know why the names come up here, DAWN and all these things. And the response rate in 110 patients was 20%. So that was a negative trial. Now, it may work in combination with something else, and we have a study at our place combining it with another drug called venetoclax. We find that not too often when two drugs like R squared, two modestly active drugs, you put them together and they're terrific. So it's still being combined with a number of other things. Now you're asking about the lenalidomide rituximab in the relapse setting. This is a study we published 2 years ago. We took rituximab relapsed patients and we randomized them to R squared on the right or lenalidomide alone. We had a third arm with rituximab alone, but no one would go on that trial. So we did this way. The overall response rate, 73-51, complete response rate, 36-13. Median event-free survival was twice as long with the combination. But one regimen that is approved is the Indolent study, which I was the international principal investigator. This was in patients who were refractory to rituximab. It did not work. We randomized them to bendamustine alone or bendamustine plus obinutuzumab with maintenance. We found a prolongation in progression-free survival with a 48% reduction time to progression, but more importantly, survival was prolonged by 42%. So this is approved. And there are lots and lots of other drugs out there in the pipeline. The gray are antibody kind of drugs. I'll be talking about most of these at lunchtime. In the middle are drugs which target the innards of the cell, the pathways inside the cell that keep it alive. And on the bottom are drugs that target that microenvironment. Lenalidomide, and then there are checkpoint inhibitors, PD-1 and PD-L1, which I'll also be talking about at lunch. And these are just some of the ongoing non-chemo trials. There are dozens and dozens and dozens of them going on all over the place. And the last thing I'm going to mention to leave more time for questions, is CAR T cells, and you'll hear about this at lunchtime also. This is a form of immunotherapy where the patient's peripheral blood cells are collected, they are modified, re-injected, and they kill lymphoma cells. It is a very active form of treatment. And there are now trials of this promising therapy, which Steve Schuster will talk about at noon, in patients with follicular lymphoma. So follicular lymphoma is a heterogeneous lymphoid malignancy. Some patients do extremely well and others not. We need a better understanding of the biology so we know how best to direct our treatments. We have an increasing number of novel agents. We are developing improved methods of monitoring patients. In our institution, we have a number of studies using the so-called liquid biopsy, which is a blood test, which is very sensitive and probably more sensitive than scans or other blood tests in detecting the presence of disease. And putting all these new therapies together and improved methods of monitoring patients, I am sure that not only will we improve patient survival, but we will improve the number of patients who are being cured with follicular lymphoma. And I will now take questions.